Welcome back to the deep dive. Today, we're tackling the heart's own electrical grid. Really intricate stuff.
Absolutely. We're looking at cardiac conduction and rhythm. It's fascinating how it connects tiny ion movements to, well, major life or death situations.
Yeah, it's fundamental pathophysiology. So we'll explore how this specialized system generates and conducts impulses.
Right. And heart muscle is unique here. It creates its own electricity, its own action potentials.
Right.
And disruptions, they can range from, just minor rhythm changes.
To really dangerous events,
No,
even sudden cardiac death.
exactly.
Okay, let's unpack this then. Our mission today, understand that normal pathway, how the electricity flows, what it looks like on an ECG tracing,
Mm,
and then really dig into the major rhythm problems, how they happen, and what they mean clinically.
sounds good. So first step is that electrical roadmap.
The conduction system pathway, it starts with these special cells, right? They
Yeah.
can self-excite, automaticity.
That's the key property. And the main pacemaker, the boss, is the SA node, the sinoatrial node.
Up in the right atrium.
Correct. Posterior wall. It has the fastest natural firing rate, setting that normal pace, typically 60 to 100 beats per minute.
But the signal doesn't just blast straight down from there, does it? There's a bottleneck.
A very important one, the AV node, or AV junction.
Hmm.
It's the only electrical connection between the atria and the ventricles, and its main job is coordination.
So it slows things down intentionally. Why?
Yeah, conduction through the AV node is deliberately quite slow. It's all about mechanics. This pause gives the atria enough time to finish squeezing blood down into the ventricles.
Before the big ventricular contractions start.
Precisely. Without that delay, the pump wouldn't work efficiently. You'd lose that atrial contribution to filling.
Got it. Essential timing. Okay, so after that crucial pause at the AV node, where does the impulse go?
It hits the express lane. The Purkinje system.
The fast fibers.
Very fast. These are large fibers, and they conduct the impulse incredibly rapidly. We're talking about spreading through the entire ventricular muscle mass in maybe 3/100ths of a second, almost instant.
Wow. And that speed is needed for a powerful, coordinated contraction.
Exactly. It ensures the ventricles squeeze efficiently to eject blood out to the body and lungs, swift and synchronized.
And the heart has backups built in if the SA node quits?
It does. Automaticity isn't limited to the SA node. If it fails, the AV node can take over, typically firing at around 40 to 60 beats per minute.
Slower, but keeps things going.
Right. And if the AV node also fails, the Purkinje fibers themselves can act as a pacemaker, but they're much slower, maybe 15 to 40 beats per minute. Definitely not ideal, but potentially life-saving.
Okay, so that's the pathway. Now let's get down to the nitty-gritty. The electricity itself. The action potential.
Right. This is all about ions moving across the cell membrane,
Mm-hmm.
primarily sodium, potassium, and calcium ions. Their movement creates sequential changes in electrical potential.
And problems with the channels that control these ions. That's becoming a bigger deal.
Increasingly so. These channelopathies, genetic defects in ion channel proteins, are now known to cause arrhythmias and even sudden death, sometimes in people whose hearts look structurally completely normal.
Okay, so walk us through the states of a heart cell, electrically speaking. It starts at rest, right? Negative inside.
That's phase 4, the resting state. The inside of the cell is about negative 90 millivolts. The membrane lets potassium leak out a bit, but keeps sodium mostly outside.
Then comes the trigger, the depolarization.
Phase 0, this is the rapid upstroke. Suddenly the membrane becomes highly permeable to sodium. Positively charged sodium ions rush into the cell.
Flipping the polarity. Inside becomes positive.
Exactly. A massive rapid influx. And this electrical explosion, this phase 0 depolarization spreading through the ventricles, that's what generates the big QRS complex you see on an ECG, ventricular contraction signal.
Now, you mentioned heart muscle is different from, say, skeletal muscle. It needs to sustain its contraction, not just twitch. How does that happen electrically?
That's the crucial phase 2, the plateau phase. This is where calcium ions come into play. Slow calcium channels open, allowing positive calcium ions to drift into the cell.
Okay.
This inward calcium movement roughly balances the slow outward leak of potassium ions. So instead of immediately repolarizing like skeletal muscle, the heart cell stays depolarized, plateaued for a significant time.
How long?
Oh, maybe 3 to 15 times longer than skeletal muscle. This extended plateau is vital for that sustained, forceful contraction needed to pump blood effectively.
And on the ECG.
This plateau phase corresponds to the ST segment, that flat line between the QRS and the T wave.
Okay, QRS is depolarization, ST is the sustained contraction phase, then the reset, repolarization.
That's phase 3. The calcium channels close and potassium permeability shoots up. Now, positive potassium ions rush out of the cell, quickly bringing the membrane potential back down to its negative resting state.
And that corresponds
The
to...
T wave on the ECG, ventricular repolarization, getting ready for the next beat.
Makes sense. Now, you hear about refractory periods, safety mechanisms.
Absolutely critical. During depolarization and most of repolarization phases 0, 1, 2, and part of 3, the cell is in the absolute refractory period, or ARP,
Meaning?
meaning it absolutely cannot be stimulated to contract again, no matter how strong the stimulus. It's a built-in protection against chaotic, uncontrolled firing.
But that protection doesn't last forever.
No. As repolarization nears completion, there's the relative refractory period, or RRP. Here, a stronger than normal stimulus can potentially trigger another beat.
Still somewhat protected, but vulnerable.
Right. And then there's this very brief, tricky window right at the end of repolarization, just as the cell is getting back to rest. It's called the supernormal excitatory period.
Supernormal sounds counterintuitive.
It means the cell is actually hyperexcitable for a moment. Even a weak stimulus, one that normally wouldn't do anything, can trigger a response here.
Ah, okay. And that's dangerous.
It's often during this tiny window of vulnerability that premature beats or more dangerous arrhythmias can get started.
Right, timing is everything. Okay, so we have the blueprint. Let's look at the ECG, again, the picture of all this electrical activity.
It's our window into the heart's function. We see the P wave,
Atrial depolarization.
then the QRS complex.
Ventricular depolarization. Atrial repolarization is buried in there somewhere, right?
Yeah, usually masked by the much larger QRS. And finally, the T wave.
Ventricular repolarization.
Correct. And a standard diagnostic ECG uses 12 different views, or leads 6 on the limbs, 6 on the chest, to capture this electrical activity from multiple angles.
And getting those leads in the right place is important.
Crucial. Improper placement can really mess up the interpretation, potentially leading to misdiagnosis. Clinically, the ECG is also super useful for detecting things like ischemia, poor blood flow, sometimes even before the patient feels symptoms.
Okay, so that's the normal picture. Now let's get into the arrhythmias. What causes the system to break down?
Fundamentally, arrhythmias arise from alterations in those core properties we discussed: automaticity, excitability, conductivity, or refractoriness.
Like too much automaticity.
Exactly. You can get ectopic pacemakers, irritable spots outside the SA node, maybe the atria or ventricles, that start firing off premature beats on their own schedule.
Okay. But you also mentioned conductivity issues.
Yes, and a major mechanism for many fast arrhythmias, the tachyarrhythmias, is something called reentry. Think of it like an electrical short circuit.
Short circuit. How does that work in the heart?
Normally, an electrical impulse travels down a pathway and then dies out.
Yeah.
But for reentry to happen, you typically need two things. First, an area of slow conduction, maybe due to scar tissue or damage.
Okay.
And second, a one-way or unidirectional block in a potential pathway nearby. So the impulse goes down the slow path, but because of the block, instead of just stopping, it's forced to circle back around and re-excite tissue that has just recovered from its refractory period.
Ah, it creates a loop.
Exactly, a re-entrant loop. And once that loop gets going, it can just keep firing around and around, generating very rapid heart rates. This can be a fixed anatomical loop or even functional, like the chaotic little circuits in atrial fibrillation.
That sounds like a recipe for trouble. Okay, let's talk specific types of arrhythmias, starting maybe with issues right at the source, the SA node.
Sure, you can have sinus bradycardia, where the SA node fires too slowly, under 60 beats per minute.
That can be normal, right, in athletes?
Yes. Highly trained athletes often have low resting heart rates because their hearts are so efficient. But it can also be pathological, a sign of trouble, maybe during a heart attack, an acute MI.
And the opposite.
Sinus tachycardia, rate over 100. Often just a normal response to increased sympathetic drive, think fever, anxiety, exercise. But it can also indicate underlying problems like heart failure or hyperthyroidism.
What about sick sinus syndrome? Sounds serious.
It often is. It usually means the SA node itself is damaged or scarred. The classic picture is persistent, unexplained bradycardia, sometimes alternating with bursts of rapid arrhythmias like atrial tachycardia or fibrillation. That's called bradycardia tachycardia syndrome.
Okay. Moving down from the SA node, what about arrhythmias starting in the atria, supraventricular ones?
Right. Atrial flutter is one. Here, you usually have a single large reentry circuit, often in the right atrium, firing very rapidly, maybe 240 to 450 times per minute.
Again, the ECG.
Gives a classic sawtooth pattern for the P waves or flutter waves.
Yeah.
Very distinct.
And the really common one?
AFib.
Atrial fibrillation. Yes, the most common chronic arrhythmia we see. It's different from flutter. Instead of one big circuit, you have multiple small, chaotic, re-entrant wavelets swirling around the atria simultaneously.
Total electrical chaos in the atria.
Pretty much. The atrial rate can be incredibly high, 400 to 600 per minute, but it's completely disorganized. On the ECG, you lose discernible P waves entirely. You just see this fibrillating baseline.
In the ventricles, what do they do?
They respond irregularly. The AV node gets bombarded with impulses and lets them through randomly, so the QRS complexes are irregularly spaced. That grossly irregular rhythm is a hallmark of AFib.
Clinically, what's the biggest concern with AFib? Stroke. Because the atria aren't contracting effectively, they're just quivering, blood can pool and stagnate, especially in a little pouch called the left atrial appendage.
Forming clots.
Exactly, thrombus formation. And if a piece of that clot breaks off, it can travel to the brain and cause an embolic stroke. That's a major risk.
You can also sometimes feel a difference between the heart rate heard at the chest and the pulse at the wrist.
Yes, the pulse deficit. The apical pulse, listening directly over the heart, might be faster than the radial pulse you feel because not every ventricular contraction is strong enough to create a palpable peripheral pulse wave.
Okay, huge implications for AFib. Let's shift to problems with conduction through the AV node. Heart blocks.
Right. These are diagnosed mainly by looking at the PR interval on the ECG, which reflects the time it takes for the impulse to get from the atria through the AV node to the ventricles. Normal is 0.12 to 0.20 seconds.
So first-degree AV block.
Simple delay. The PR interval is consistently prolonged, longer than 0.20 seconds. But every single atrial impulse still makes it through to the ventricles. The rhythm is regular. Usually it causes no symptoms.
Okay. What about second degree?
Now we have intermittent failure. Some beats get through, some don't. There are two main types. Mobitz type I, also called Venkebach. Yeah. You see a progressive lengthening of the PR interval over several beats, longer, until suddenly a QRS complex is dropped completely. Then the cycle resets.
Kind of a warning sign before the dropped beat. Is that one dangerous?
Usually type I, Venkebach, is considered less serious. The block is typically higher up in the AV node itself and often transient.
But there's a type 2.
Yes, Mobitz type 2. This one's more concerning. Here, you have intermittently dropped QRS complexes, but the PR interval of the conducted beats remains constant. There's no progressive lengthening warning.
Why is that one worse?
Because the block in type 2 is usually located lower down in the conduction system, like in the bundle of His or bundle branches, it's much more likely to progress suddenly to a complete block, and it carries a higher mortality risk.
And complete block is third degree.
Correct. Third degree AV block or complete heart block. Here, the electrical connection between the atria and ventricles is completely lost. They are electrically dissociated.
So the atria beat at their own rate, and the ventricles.
The ventricles beat at their own, much slower escape rhythm, usually driven by a pacemaker site below the block, maybe in the AV junction or the ventricles themselves. The rate is often very slow, like 30 to 40 beats per minute.
That sounds like it would cause problems.
Big problems. Cardiac output drops dramatically. Patients often experience dizziness, fatigue, shortness of breath, or even syncope fainting spells, sometimes called Stokes-Adams attacks. This is a medical emergency requiring pacing.
Okay, those AV blocks are critical. Now let's move into the ventricles themselves. Ventricular arrhythmias. These sound like the most dangerous.
They often are, because they directly impact the heart's main pumping chambers. We can start with premature ventricular contractions, or PVCs.
Those extra early beats from the ventricle.
Exactly. Caused by an ectopic focus, an irritable spot, within the ventricle firing off early. On the ECG, a PVC looks different. It's typically wide and bizarrely shaped because the impulse spreads slowly through the muscle, not the fast Purkinje system.
And there's often a pause after it.
Yes, usually followed by a compensatory pause before the next normal beat comes through. Occasional PVCs can be benign, lots of people have them, but frequent PVCs, especially in someone with known heart disease, can be a sign of trouble or indicate things like digitalis toxicity.
What if those PVCs start happening one after another?
Then you get ventricular tachycardia, or VT.
Okay.
That's a run of 3 or more consecutive PVCs. The rate can be anywhere from, say, 70 up to 250 beats per minute.
Still wide, bizarre QRS complexes.
Yes. VT is dangerous because at faster rates, the ventricles don't have time to fill properly, and you lose that coordinated atrial kick. Cardiac output can plummet, leading to low blood pressure, loss of consciousness, or it could degenerate into, well, worse rhythms.
Like ventricular fibrillation. But before that, what about long QT syndrome?
Ah, yes. LQTS is a condition where the repolarization phase 3, the T wave, is prolonged. The QT interval on the ECG is longer than normal
And why is that dangerous?
because that prolonged repolarization increases the risk of those vulnerable periods, especially triggering a specific, very unstable type of polymorphic VT called torsade de pointe.
Torsade the point. Twisting of the point.
Exactly. On the ECG, the QRS complexes look like they're twisting or spiraling around the baseline. It's highly unstable and can quickly deteriorate into ventricular fibrillation.
Which is the ultimate electrical chaos.
VFib, yes. Grossly disorganized electrical activity throughout the ventricles. There's no coordinated contraction at all, just quivering. No effective cardiac output, zero.
Life-threatening emergency.
Immediate. Requires defibrillation right away to try and shock the heart back into some kind of organized rhythm.
And just to circle back quickly, those inherited channelopathies we mentioned earlier.
Right. Things like congenital long QT syndrome, Brugada syndrome, short QT syndrome, CPVT. These are genetic defects in ion channels that predispose people, often young, otherwise healthy people, to these life-threatening ventricular arrhythmias and sudden cardiac death, sometimes triggered by specific things like stress or exercise.
Truly devastating. Okay, so we've covered the types. How do we diagnose and treat these complex rhythms?
Diagnosis starts with the basics, the surface ECG. But arrhythmias can be intermittent.
Right, they might not happen while you're getting that 10-second ECG strip.
Exactly. So for symptoms that come and go, we use longer-term monitoring. Holter monitoring captures maybe 24 to 48 hours of continuous ECG. For even rarer events, patients might get an implantable loop recorder, a small device under the skin that can monitor rhythm for up to 3 years.
What about bringing out the arrhythmia, provoking it?
That's where exercise stress testing comes in. See if physical exertion triggers rhythm changes or signs of ischemia. And for the most complex cases, or when we're considering procedures like ablation, we do electrophysiologic studies, EP studies.
Invasive.
Yes, it involves threading thin electrode catheters through blood vessels into the heart chambers. This allows us to record electrical signals directly from inside the heart, map out conduction pathways, and even intentionally stimulate the heart to try and induce the arrhythmia safely in a controlled setting.
Locating the source of the problem.
Precisely, finding the arrhythmogenic focus.
Okay, once diagnosed, what about treatments? Drugs?
Pharmacologic therapy is often a first step. Antiarrhythmic drugs are broadly classified based on how they affect the action potential.
The different classes.
Right. Class I drugs, like lidocaine, block sodium channels, slowing down that rapid phase 0 depolarization. Class II are the beta blockers, like metoprolol. They primarily slow the heart rate by reducing sympathetic effects.
Okay, class 3.
These block potassium channels, like amiodarone or sotalol. By doing that, they prolong repolarization phase 3 and extend the refractory period, making the heart less likely to respond to rapid stimuli.
In class 4?
Calcium channel blockers, like verapamil or diltiazem. They mainly work by slowing conduction through the AV node.
So drugs target specific ion channels or receptors. What about electrical treatments?
Big category. For slow heart rates, like symptomatic bradycardia or high-grade AV block, the answer is usually a cardiac pacemaker, a device implanted under the skin with leads going to the heart to provide electrical impulses when needed.
And for the fast, chaotic rhythms, shocks.
Yes, electrical cardioversion or defibrillation. The goal is to deliver an electrical shock to depolarize a critical mass of heart muscle simultaneously, interrupting the chaotic rhythm and hopefully allowing the SA node to regain control.
Is there a difference between cardioversion and defibrillation?
Key difference is timing. Cardioversion is synchronized. The shock is deliberately timed to the R wave of the ECG. This avoids delivering the shock during that vulnerable T wave period, which could actually induce VFib. We use synchronized cardioversion for organized tachycardias like AFib, flutter, or stable VT.
And defibrillation.
That's an unsynchronized shock, used emergently for life-threatening disorganized rhythms like ventricular fibrillation or pulseless VT, where timing doesn't matter. You just need to reset the heart immediately.
Got it. And for people at high risk of these sudden events?
We have automatic implantable cardioverter defibrillators, or AICDs. These devices are implanted like pacemakers, but they constantly monitor the heart rhythm. If they detect dangerous VT or VF, they can automatically deliver pacing therapy or a life-saving shock.
Incredible technology. Finally, what about physically fixing the source of the arrhythmia, ablation?
Yes, this often follows those EP studies where we pinpoint the problem area. Catheter ablation involves guiding a special catheter to that spot inside the heart and delivering energy, either radiofrequency energy to heat and destroy the tissue or cryoablation to freeze it.
creating a small scar to block the bad circuit.
Exactly. You're essentially destroying or isolating that small area of tissue that's causing the reentry loop or the ectopic focus. It's like surgically removing the short circuit, but done minimally invasively through catheters. Highly effective for many arrhythmias like SVT, flutter, sometimes AFib, or even VT.
Wow. That's an amazing journey through the heart's electrical system. We went from, the basic cellular automaticity, track the impulse through the SA node, the critical AV delay, the fast Purkinje system. We saw how ion movement, sodium, calcium, potassium create the action potential phases and map directly onto the ECG waves like the QRS and T wave.
Right, and understanding those refractory periods, especially that tricky supernormal phase.
Yeah. And then we explored the breakdown's ectopic beats, the crucial concept of reentry causing tachycardias, distinguishing atrial issues like AFib with its stroke risk from the immediately life-threatening ventricular ones like VT and VF.
It really highlights the complexity, doesn't it?
Oh.
And how narrow the window is for normal function. So what does this all really mean for, say, a student learning this?
Good question.
Well, understanding these details is critical clinically. Knowing the difference in prognosis between a first-degree AV block and a Mobitz type 2, based on that PR interval, that directly impacts patient management. One might just be observed, the other needs urgent attention, maybe a pacemaker, to prevent fainting or complete heart block.
It translates directly to risk, syncope, stroke.
Absolutely. The ECG isn't just lines on paper. Those intervals and shapes tell a vital story about electrical stability or instability.
So here's something to think about. The entire moment-to-moment function of your circulatory system, keeping you alive and conscious, hinges on the perfectly timed opening and closing of microscopic gates controlling just 3 key ions, sodium, potassium, and calcium.
It's profound when you boil it down like that.
Whether those tiny movements stay synchronized or spiral into chaos determines everything. This electrophysiology is really the bedrock for understanding almost every critical heart condition. Thank you so much for taking this deep dive with us today.